Welcome to Between Two Ovaries, your go-to for all things women's health.
A lot of people just say like, oh, my vagina.
Yeah.
And
Yes.
that's
all
not,
of the above.
That's not your vagina.
No.
Well, it is.
We're here to cut through the confusion, bust some myths, and give you the facts straight from the experts.
You cannot still believe the amount of people that come to a gynecology clinic saying that they don't look right down there and they need something doing about it.
We're keeping it real, bringing you honest conversations about topics that matter to you.
Everything goes back to the menstrual cycle. Yes, it's a low-risk procedure, but it's not a no-risk procedure.
From periods to menopause and everything in between, we've got you covered.
So whether you're here to learn, laugh, or just listen, you are in the right place.
As soon as I said it. Today, we are beyond excited to welcome the incredible Dr Paula Briggs to the pod, a true powerhouse in the world of women's health, previous chairman of the British Menopause Society, and one of the UK's leading voices in menopause care. Paula's a consultant in sexual and reproductive health with decades of clinical experience, and what she doesn't know about menopause, quite frankly, isn't worth knowing. She's here to bust myths, share the evidence, and help us make sense of a topic that's still too often misunderstood. We're so excited to have you here to chat all things menopause when one size does not fit all. Thank you so much for joining us.
Thank you for asking me.
So I am honoured to say that you're our first Scottish guest, which is big for me. We know that you now work at Liverpool Women's Hospital. Can you tell us how you ended up at the Women's and what your week looks like?
Yeah,
day by day?
So we moved from Glasgow in 1993 for my husband's job. Initially I was a GP, and then I transferred specialty to sexual and reproductive health, and initially I worked in Southport and Ormskirk, and then I transferred to the Women's to do an MD.
Oh, so research brought you to us.
Yeah.
I didn't know it was actually the research that it brought you. I thought you kind of got a job and then, kind of migrated into doing some research.
No, so I was already doing the research project, and it was just really difficult not being able to kind of collaborate on site. So I was really lucky to get a job at the Women's.
Perfect.
Well, we're very lucky to have you at the moment.
Yeah.
So works both ways.
And for the listeners, I find it difficult sometimes to work out it's usually when people aren't medics, but when people are medics even, what do you do? So what do you do on a Monday, Tuesday, Wednesday? How do you split your week up? Because you are now research nurse done. Paula has now got her MD.
Yeah, not quite graduated, but I have finished.
Almost doctor.
So when I was doing the MD research project, I worked Wednesday, Thursday, Friday, but since that's finished, I now have a full-time job. So Monday I do some commercial study research. Tuesday I work in the community doing menopause as a sort of integrated service with a GP. Wednesday I tend to do either menopause on the phone, which actually it works well, or a theatre list. Thursday I do a vulval clinic, and we either do PMDD as a joint clinic with psychiatry, which is really useful just to get various people's opinions because it's a complicated condition, or we do HRT implants, and on a Friday I do a hysteroscopy list. So I'm really lucky. I've got a really sort of varied working week, and a little bit of everything.
Keep you on your toes.
Yeah.
Well, we should say, so PMDD is premenstrual dysphoric disorder, and we did an episode not too long ago with part 1, which is all about it.
Yeah.
And part 2, we had an interview with a patient who has PMDD as well.
Oh, amazing.
So if anyone listening that wants to listen to those,
Go check
those out.
Oh, it's a really complicated condition. I love your week though. It seems like so many different little aspects. It will definitely kind of keep it really interesting for you. And
It does, and it's quite nice doing telephone clinics because you get to stay at home, which has its benefits, doesn't it? But it's also nice, I think, to go to different sites, and it's nice to work with different people, different specialties. And I think we're all really lucky working with patients. It's very varied anyway.
And with that whole working with the GPs as well, and having an integrated care situation with menopause services, that's kind of what people want. They want to be seen quicker. They want to be seen by somebody that knows what they're talking about. And they don't want to be waiting forever because symptoms kind of don't get better, they usually get worse, or the person gets more frustrated.
So I don't think menopause should be a secondary care specialty. I think 90% of women roughly would be better managed in primary care, but obviously GPs need support. So one of the other things I do on a Monday is a GP Teams meeting. So instead of the GPs referring the patients to us, they talk about cases, and there might be, I don't know, 6 or 12 GPs, but they all listen to the different cases, and that's a real learning opportunity. And we've also set up Liverpool Women's Menopause Academy, so I think about 60 GPs now have been through for training. And it's really good because if I know who the patient's GP is, then I will see them and discharge back to the GP, and the GP knows that they can come on the Teams meeting if they need support. You know, there's probably, 6 or 7 different ways to manage any one patient. So sometimes it's just a case of them running by me and the other people on the call what they intend to do, just for that reassurance that that's an okay thing to do. And I think that is a really supportive way of managing patients. And the patients that we should be seeing are women who've got premature ovarian insufficiency, premature menopause, so women under the age of 40 who may have fertility issues and lots of other things that need to be managed. Women with cancer. So we work really closely with the breast oncologists and surgeons, and also the gynae oncologists. And I think that is the benefit of a secondary care service, very different, for example, to a private menopause clinic.
That's really what we wanted to touch on today as well. So that brings us really nicely to what we're going to do this episode. So we wanted to initially just start with a bit of a recap of what menopause is, what perimenopause is. But because you're here and you're such an expert, we wanted to delve more into HRT prescribing in those difficult, complex situations. So we'll sort of talk through a little bit about cancer, a little bit about breast cancer. And we'll quiz you a little bit. And we have some questions from people that have sent in their questions for you as well.
Yes. Yeah.
So could you just tell us from the top sort of what is menopause, what is perimenopause?
Yeah. So menopause is quite easy to define. It's 12 months after a woman has her last menstrual period, then she's postmenopausal or menopausal. What's much more difficult to define is perimenopause. And what we are seeing currently, because there's been such a explosion really about menopause, lots of awareness, which is great, but we're seeing younger and younger women who feel that they might be menopausal. And at the same time, those women are not using contraception because there's a kind of anti-contraception movement, despite the fact that these are all female hormones. So instead of using hormonal contraception, younger women who are still menstruating are choosing to use hormone replacement therapy, which doesn't necessarily provide contraception unless they're using an intrauterine device with a hormonal core.
Is that because they think that they've kind of decided they're perimenopausal and need the HRT for that?
If we talk about menopausal symptoms, the things that we can say are definitely menopause in appropriately aged women, or depending on their sort of menstrual cycle, are hot flushes, night sweats. That obviously impacts on sleep, that results in brain fog. But the thing that is much more difficult to clearly identify with menopause are mood-related symptoms. And there is a real focus on mood-related symptoms and managing that with hormonal therapy. And like I said before, we do joint clinics it's perinatal psychiatry, so psychiatrists that have an interest in female hormones. And that makes a huge difference, because menopause may impact on mood, but it's not necessarily the best way to treat mood-related disorders. And I think managing a menopausal woman is like putting pieces into a jigsaw. You might give them HRT, but you then might need to add other bits. You might need to add antidepressants, you might need to add CBT, and often we need more than one thing to get them better. And the other thing which is associated with menopause, and I think we are going to talk about that later, is genitourinary syndrome of menopause. So that's vaginal dryness, itching, burning, pain with sex, recurrent urinary tract infections. The other area, which again is less clear, is musculoskeletal symptoms. Again, that you've got aging to factor into that. You've got sort of genetics. And you can't manage that with hormonal therapy alone, in my opinion.
I think it's difficult with this whole new surge, and it is a new surge. So we had like the Davina effect, and that kind of, we did. And there has been these have been studied, like they had the Jade Goody effect when everybody went for their smears. So you've had a Davina effect with the fact that everybody's like, HRT, should we all go on it? It's amazing. We should all be on HRT and testosterone and all these different things. But I feel like now there has been a surge of younger celebrities that have said that they're perimenopausal, and they're quite young, like 35, 36, 37.
And you'd expect menopause to start
so it's difficult because there is
the problem.
the vast majority of women will become perimenopausal in this country around the age of 46, but the average age of menopause, so when periods have stopped, is 51. But it can happen younger, and I think people don't want to miss the diagnosis. They don't want to fail to think about that. But the pendulum has swung too far, in my opinion. You know, instead of thinking, could this be anything else? People are saying it's menopause, it's menopause. And there are other causes of night sweats. You know, it could be cancer, it could be TB. And I think to have that tunnel vision that everything is menopause is actually very dangerous. And we then are failing to address all the needs of the patients. The other thing, which we have to factor in, is women do not want to be told that they need antidepressants. And that's very real, and that's really difficult. And look, having done menopause management for at least 3 decades, a long time.
Yeah. You were doing it from when you were a teenager.
Yeah, exactly. We used to find patients were really happy, and now we are seeing more and more women who are really upset when they come back because they don't feel amazing, because it's not a cure-all. So, you know, it is a package of care, and it involves looking at diet, exercise, factoring in ageing. Sleep is really difficult because, you know, if you get somebody whose menopausal symptoms resolve with HRT, so hot flushes and night sweats go, and for a bit they might sleep better, but then they might stop sleeping again. And it's so complicated, sleep. And it does, you know, it has a huge impact on well-being.
On all parts of your life.
And I think we just have to think much more widely about how to manage women and to set their expectations, because, you know, celebrities have other resources, don't they? They will have, I don't know, a dresser, a hairdresser, a makeup artist, things that make them feel amazing that a lot of our patients don't have.
We had a chat when we've touched on this previously, and it's kind of that we said that if your life is rubbish and you hate your husband and your job is terrible and your children are really annoying you, going on HRT will not solve those problems. And it's not being rude, it's actually kind of being specific. And I think this expectation setting, I do a lot of expectation setting in my job, is real, and we need to not be promising the world to people, because it's not everybody wants a tablet that can cure everything. And I think with the jabs recently, with the weight loss jabs, they have been a bit of a revolution with that side. But it's that they want something very easy that isn't going to be you saying, well, if you take up some exercise and your diet's good and you've got, like, they actually don't want to hear that.
No, they really don't want to hear that.
Yeah, the easy fix is taking a medication, isn't it? And it's the same with everything, like you say, with the weight loss jabs. It's having to listen to, you need to change your lifestyle and then actually act on it is really difficult for everyone. But if you can be offered a medication that you expect to do the same thing, you'll take it and you'll hope that it'll work. But unfortunately, it doesn't solve everything.
Hormonal replacement therapy. What actually is it? What are we giving them?
Yeah, so it depends where they are on that journey from reproductive to post-reproductive life. But if it's somebody who is still having periods, then generally speaking, we provide something called sequential HRT. That means that part of the month we provide a progestogen to protect the lining of the womb, and for all of the month they get estrogen.
Okay.
There are various different ways of providing HRT. We touched earlier on a device which provides that protection, and that is a much better way of doing that, because actually really there's nothing good about bleeding. If you try to give somebody 2 hormones too early, then they're likely to get chaotic bleeding. But once somebody's periods have stopped, like a year after the last period, the recommendation is that we give 2 hormones all the time, because that provides better protection for the lining of the womb. And ideally they would be bleed free. But the problem is, for us, hormonal therapies cause bleeding. They stimulate the lining of the womb. And we've seen like a massive increase in the number of women presenting with abnormal bleeding, and it's worrying for them. They often come through an urgent suspicion of cancer pathway, which is alarming anyway. And then they have ultrasounds, biopsies, camera tests, things that are really not very nice. And the best option for those women is the device with the hormonal core, but it's really quite difficult to persuade women to have that. I mean, a lot of women are not keen on that.
Yeah, we see that a lot. That's why we did an entire episode on the Marina.
Oh, did you?
Yeah. That was our first ever episode.
Yeah.
It's just as you say, a lot of people have a kind of aversion to hormones, whether it's for contraception or for HRT, maybe less so for HRT. But we saw a lot of people who would benefit from having the Mirena or the hormone coil were not wanting it because of their misconceptions and trying to break that down. So we decided to do the whole episode on it.
It's actual hormone hate.
So I kind of think Mirena, we'll call it Mirena, although there are 3 devices that are the same, can surf the menopause transition. So it takes you from reproductive life, when you ideally would have good contraception, something that would reduce bleeding because bleeding's not good, and then as you go through towards menopause and you become symptomatic with flushes and sweats or difficulty sleeping or whatever, you add in some estrogen. And I think one thing that kind of has gone wrong is people are using extremely high dose estrogen. So if they don't feel completely better, instead of thinking, are there other things that I could do, they just use more and more and more of the same, and then they get really high levels which can cause abnormal bleeding, and then they're into the whole needing investigated.
And you're definitely on the same camp as us, because we say all the time that you don't need to have bleeding. So you don't need to have bleeding while you're on contraception. You don't need to have bleeding while you're going kind of through this transitional time in your life. So I think people get really stuck on having periods, and we're like, why? Why do you need a hormonal break? Why do you need this?
Why have your period when really you can just not have your period and you're still...
Well, there's just loads of myths out there, like you have to have a hormone detox. So I've been on the pill for 7 years and I've decided to have a detox. There's no benefit to that. Or
nothing good comes from taking a break.
No, you're bleeding and then you're going to go back on it, aren't you? Like, what's the point?
So just back to those perimenopausal women, the earliest sign generally is a change in bleeding pattern. So periods might come more frequently, or there may be longer gaps, they may be heavier, they may be quite unmanageable. But as I said, those women are still potentially ovulating and they're still producing estrogen, and they do at times have really high levels of estrogen. So if you give them more estrogen, then they are likely to get spiking, which can trigger things like migraine. So I think the better way to manage those younger women, so below the age of 50, if they don't want Mirena or the equivalent, is to use some of the newer combined pills which contain natural estrogens like estradiol, estetrol, which is fetal estrogen. And there are 3 different options. Clara is a pill which has got estradiol valerate, that gets metabolized, so made into estradiol. We've got Zoli, which has got estradiol, and we've got a pill called Drovelis, which contains fetal estrogen. And fetal estrogen is found in really high levels in pregnancy, and that's associated with less breast cancer risk, less risk of blood clots. And all of those pills are associated with a reduction in bleeding, with good contraception, and exactly the same hormones as women would access through HRT. So it gets rid of any anxiety. But, just to kind of hint at how complex this is,
I was just going to say, do people want that though?
We get women on the pill who say they're menopausal and they're symptomatic, and if you're on a combined pill with ethinyl estradiol, which is a very potent estrogen, then you wouldn't get menopausal symptoms. So in that situation, it could be anxiety and it could be something else, and changing those women to HRT, in my opinion, just increases the risk of abnormal bleeding.
It's difficult, isn't it? Because you kind of giving them in the information, but they're seeing them as totally different things. It's like when you use the pill for different circumstances, if that's for like when people are young and they've got heavy periods, or your skin, or that. It's like very much, it's like, well, that's the combined oral contraceptive pill. So it's what I'm using for contraception, full stop, the end. I now feel like I'm perimenopausal, therefore I need to be on HRT. There isn't like
there's not a nice crosstalk.
So we were talking recently about kind of rebranding those natural estradiol pills as contraceptive HRT. And in fact, there's a lot of talk about changing HRT to MHT, in most countries now call menopausal hormone therapy, because it's not a deficiency state and it is a treatment option. So I feel
like that would be more accepted.
I think it would be a better way to...
It's like with the coil. The coil sounds horrible.
Yeah.
And
A giant slinky
device is not a coil. As in, it's not a coil shape. But if you call it a device, it sounds much more acceptable.
I think it sounds most acceptable if we just call her Mirena.
She's our friend.
Can we touch on exactly which menopausal symptoms are improved by HRT? Because I think that's something that we...
So there's a real push at the moment.
Would help your life in general.
There's a real push via kind of social media channels to say that mental health problems are totally linked with hormones. And like I've said already, it's much more complicated than that. So the things which will go are hot flushes and night sweats. And if women use vaginal estrogen in addition, then the genitourinary syndrome of menopause symptoms will also go. Those are the things that we can definitely improve. The other things might improve, but not necessarily. And we haven't touched on low libido yet, but that's linked with genitourinary syndrome of menopause. It's linked with life, with length of relationship, with things that are going on, with sleep deprivation. Everything feeds into that. So that's a multifactorial problem, and it's very simplistic to think that testosterone for women will solve that problem. And in reality, as you get older, as a woman, your freely available testosterone levels actually go up because sex hormone binding globulin, which is like a protein, goes down. So we are literally overwhelmed by women requesting testosterone because they believe that that's going to cure a whole range of different symptoms. It is indicated for low libido, but again, my expectation setting for women who ask for testosterone is to say this might improve low libido for about 1 in 10 women. I genuinely believe it is as low as that. We are obliged to check a level at baseline and then again at 6 weeks, so all that's very time consuming and costly. It's quite labour intensive, and then to review that patient at 6 months. So what I am saying to them at the outset, I don't mind you trying it because you could be that woman that
you could be the
amazing.
1 in 10,
But if you're not, and if you're not seeing a really significant difference, you're just adding another thing to do and another thing that has to be monitored.
Is there any way that, just through your experience, can you kind of tell who it might be beneficial for?
No.
It's just completely
not like to do with the symptoms.
And who, how would you prescribe testosterone, in what form?
So at the moment we use male products outside of licence, which again is problematic because the leaflet is very much geared up for men. At the women's, we use Tostran. It's a pump dispenser. Men use it daily and they use more than one pump daily. Women are advised to use one pump, either alternate days. But alternate days is tricky because sometimes we don't remember, did we do it the day before? Sometimes we can't remember, did we do it 5 minutes ago?
Especially if one of the symptoms is brain fog.
So Monday, Wednesday, Friday we generally say, which is easier to remember. And each pump gives a woman 10 milligrams of testosterone, and the recommended amount for women is 50 milligrams over 10 days. So we're slightly under dosing. In future, we will hopefully have access to Androfem, which is a product marketed specifically for women. It's a cream, and it comes with a syringe, so it's much more specific than using, say, Tostran. Or there are other products like Testim, which is a screw top tube, or Testagel, which comes in a sachet. Now that's really tricky because you have to seal the sachet with a paper clip or a Kirby grip. And is that going to do something to the gel? Well, possibly. We don't really know, so that's not ideal at all.
When you say it's a pump, is it a pump of like moisturiser?
It's like a pump of jelly. So estrogel is another. You rub it on your skin, either below the belly button and the lower abdomen or on the anterior thigh. They're the kind of recommended sites, because one of the side effects of testosterone is hairiness at the site of application, not generalised increased hairiness, but it can be really quite extreme. So we used to say here on the palmar aspect of the forearms, because there's no hair follicles, but then women were starting to get really hairy on their forearms. So now we just stick with the anterior thigh or the lower abdomen, because it's really easy to remove hair from there.
And a bit
So,
more
it's not completely free of side effects, testosterone. Some women will get acne, they'll get hair changes like male pattern baldness here. So I think we have to be really quite careful. And, one of the downsides to all the publicity about menopause is there are hundreds of videos available, freely available, provided by non-medical people demonstrating how to use HRT. And there's a real tendency to go for estrogel, which is a pump dispenser. The highest licensed dose of estrogel is 4 pumps. Now, they're quite big volume, the pumps, so you put them on the thighs and the back of the shoulder. People are using more than they're advised to, because it's very easy, and they think, I'll just have a little bit more. There is another gel called Sandrina, which comes in a single dose sachet. It's a smaller volume, and I think it's better absorbed. There's also patches. Now, anecdotally people will talk about them coming off, so that's problematic depends on skin type. And Lenzetto is a spray, but there is now a real tendency for everyone to use transdermal, so that's through the skin as a patch, a gel or a spray, because that doesn't have the same impact on the risk of blood clots that oral HRT has. And if we have somebody who's got a body mass index over 30, which lots of our patients do have, then they already have an increase in the risk of blood clots. So I can understand why we've kind of moved almost completely to through the skin, but at the same time some women do not respond to transdermal HRT, and if you check a hormone level, their estradiol level might be below 100, so completely sub-therapeutic. Now, if you're not responding to something in the highest dose, in my mind, it's not logical to keep giving more and more and more of that same thing. Think about changing the delivery route. So in that situation, if the patient had no contraindications, I would definitely say oral HRT has a place. And, years ago, we didn't have the option of all these transdermal products, so I think we're missing out on the benefits of oral HRT. And the other thing which has happened is this desire to use body identical hormones. Well, all of the hormones that we give are made synthetically. They might look, if you looked at the chemical structure, identical to the hormones that your body produces, but
still made outside.
They're all synthetic. So, and the differential between synthetic progestogens and body identical progesterone are very small, and body identical progesterone is not the best for protecting the lining of the womb. So not only have we seen an increase in the number of women bleeding, but we've seen an increase in the number of women who've got hyperplasia, which is a risk factor for cancer. And I don't want to appear to be really negative here. I am pro HRT, and I think all women should be given the information about managing menopause way ahead of becoming menopausal, so that they can make an informed decision. But I think things currently have gone to the point where there's that FOMO, fear of missing out. That's why younger women are coming forward and saying, I must have HRT because I've got all these symptoms. They're nothing to do with menopause, actually.
Can I ask a rogue question? With the hormones, how people want body identical, how are they made?
No, they're made in a lab. Yeah,
so they're a bit synthetic too. Yeah. That was just something that suddenly came to there, and I was like, how are we getting these? Who are we farming these from?
I've got this kind of concept that hormones all look a bit like chicken wire, and they all look really, really similar, and they all interact with each other's receptors. But if you've got estradiol and an estradiol receptor, it's a perfect fit. Whereas if you've got progesterone, it will interact with a perfect fit with its receptor, but some of the synthetic ones will interact with the androgen receptor and the estrogen receptor as well. So you get different features with different progestogens, and you can tailor the beneficial effect to the individual woman's needs, I think. So I think there's a real role for some of these synthetic progestogens.
I was just checking we weren't farming them. No. I was like, what are we doing?
That does seem to have been like a real social media thing.
I was just going to say,
body identical.
Who shouts loudest hormones regarding this? I feel like body identical is being shouted very loudly.
And testosterone is also being shouted really loudly. And I feel really sorry for women, because women now don't know who to trust with their information.
And could feel inadequate, because you're like, oh, maybe I need to have testosterone. Like, what's my testosterone? Or am I perimenopausal? Am I, like, I don't know. I feel like it's way more, like, in any kind of social gathering now, and I'm 41, but, like, so many people are like, oh, it's my menopause, and you're like, well, it's probably not, because you're the same age as me. But, like, it's definitely like something that flies out all the time.
It's a good thing that people feel comfortable to talk about menopause, perimenopause, and it's not like something to be ashamed of. But then the downside of that is that it maybe is used when it doesn't actually fit, like you say. Like, there could be other things causing those symptoms.
We're still being led to believe it's a taboo. I genuinely do not think menopause is any longer a taboo, and I think that that's a good thing. But putting everything down to menopause is not a good thing.
No. I think men do it as well. They'll be like, oh, she's so menopausal, she's going on about this.
But, sort of older women achieve so much, and I don't think...
To say that you can't, I have seen this a lot. So, like, once you're menopausal, you're not going to be able to achieve X, Y, and Z. This is what happened. I was overlooked for this, this, and this. And I'm like, that doesn't happen to everybody. And I don't think that narrative needs to be voiced for everybody, because everybody's going to be very different. But it is difficult when it's very much out there at the moment.
Yeah, so I kind of feel with menopause we've lost our direction a little bit. I think when the NICE guidance was published in 2015, that redressed a lot of myths from previous clinical trials, research projects. And we were just building on that when we got COVID. And then also, general practice is a very difficult job, and I think lots of younger, particularly female GPs, are leaving and becoming menopause specialists. Well, menopause is not a specialty. It's a part of gynecology, of general practice, but it isn't a specialty in its own right. So you're either, I think, a specialist on the specialist register, or you're a GP, and GPs do everything, which is difficult. But I don't really think having a private menopause clinic is a good thing, and I've changed my opinion about private services, because you only get a very tiny ring-fenced area, whereas it's better to come, I think, to either a clinic where you can get everything, or to see a GP who's got a much more holistic view of managing symptoms.
It does make sense, you know, because it is something that every woman will go through, and half of the population, well, just over half, are women. So it makes sense for it to be a primary care, a GP thing initially.
Exactly. It needs to be normalised, you know, like contraception, pregnancy. This is just a part of our lives. It doesn't need to be picked out and focused on. And, you know, being really controversial, it's become a marketplace, and people are making a lot of money out of menopause.
We did an episode specifically about HRT. If you are someone that wants it and is suitable for it, what do you need to know? So it was quite a kind of spotlight on HRT.
And progesterone, if you've got a womb, that kind of situation.
Within that, we did talk about how, you know, you don't have to medicalise menopause. If you're someone that doesn't need any medication for it, it's okay. It's like everyone will go through puberty, and some people will sail through it and be fine, and some people won't. And menopause will be the same. Everyone will have a different experience. But I think sometimes, because the media talks so much about testosterone and HRT, you might just think, well, if I'm menopausal, I have to have HRT. You don't necessarily have to, is the other thing.
So can I just say, we've done booklets with Carger, a publisher, that are free. So we're not making any money, but this is the right information. The general menopause booklet has just been published. It's the 3rd edition. It reflects the recent NICE guidelines, which are much more conservative, I think, because of the, you know, countering the sort of explosion and the sort of non-safe practices that are going on out there. We've also done one specifically about urogenital atrophy, and one for women who've had gynecological cancer. And I think having a free resource that isn't about a specific person, so it's a generalised information resource is useful.
We will link those.
Also, I think we should explain what NICE guidelines are.
Oh yeah. So NICE guidelines, NICE is a body that produces these guidelines, and they produce them for lots of different things. So there's a fertility guideline, there's a cardiovascular disease guideline, there's guidelines for everything, but there is a menopausal guideline. And in the menopause guideline that came out just recently, it really took a step back about what HRT was actually useful for, and was very much of the opinion that it's only been proven to help with like hot flushes, night sweats, and it's not really been proven to help with anything else.
Is it kind of like NICE guidelines, like a curriculum? Almost.
It's supposed to bring evidence together from all different places, good quality evidence, to kind of inform us what's best to do with regards to management, prescribing, and that kind of thing. But I don't think people were expecting it to be that conservative.
No. Yeah, it did kind of take a step back. You know, things like not using HRT specifically for its bone-sparing properties, although it does do that. There are other ways of protecting bone, taking vitamin D, calcium, exercise, a healthy diet. All of those things are really important.
Yeah, I think there was a lot of people that were like, oh, that wasn't what we thought it was going to
say.
So
the one thing that was very controversial, and we had the lead author come and speak to us as clinicians at the Women's, was the fact that there was no cardiovascular protection. I mean, that had been talked about really for years before that. If you start HRT in the perimenopause, it's good for protecting cardiovascular health. And I think the rationale for that was, if you already have somebody who isn't looking after their health, so they might have type 2 diabetes, high blood pressure, be overweight, then giving them HRT absolutely is not going to change their cardiovascular risk profile. So, you know, it's really important to get in there early on and look at lifestyle changes. And it is hard. I think, you know, people are lots of people are living in poverty, and it's much more difficult to it's just, I think, being positive and if you feel really down, you're much more likely to have a cigarette and a glass of wine than to go for a 5-kilometre run. I mean, that's just life, isn't it? So I think, you know, some of how we manage women is to allow them to talk, but it can be quite difficult. You know, I talked about doing telephone clinics all day on a Wednesday, and if you don't see somebody and you have 12 patients in the morning and 12 in the afternoon and it's similar stories, it's exhausting.
Yeah.
Really.
We wanted to touch on the more complex situations. So, for example, breast cancer and HRT. Is there any guidance that you're aware of that helps people deciding whether or not it's safe to have HRT if they've had breast cancer?
So breast cancer is another area that I'm really concerned about. There's a real kind of movement for women to be told that it doesn't matter if they've had breast cancer, and this is coming through the private sector primarily, that the increase in risk of recurrence is very small. Now, I don't believe that. I think breast cancers are diverse. It depends on the individual circumstances. And like I said before, we work really closely with the oncologists and the breast surgeons, and I wouldn't want to make a decision about whether somebody should have HRT after breast cancer without collaborating with those colleagues. And I think from the patient's perspective, that's really important. I'm not saying I've never given HRT to someone with breast cancer, because I have, but I would never say to a woman who'd had breast cancer, even receptor negative, triple negative breast cancer, that there's no risk of a second breast cancer or of a recurrence, because I don't know that's true. What is coming to market are new drugs called neuroendocrine therapies, which are non-hormonal, and they influence the hot flush centre in the hypothalamus. And so I think, rather than sort of, you know, it's almost like a human experiment saying to women with breast cancer, it doesn't matter, you can have body identical HRT. Well, you know, they already had their own hormones when they got breast cancer. So saying you're okay with body identical is illogical. But to treat them so that they don't have hot flushes and night sweats, that makes a massive difference to quality of life. And I can think of one patient who we provided one of the neuroendocrine therapies for. She hadn't slept for forever. She went home, she took one, she slept for 3 hours. She woke up bone dry, and she just said, oh my God, you know, this is a totally life-changing treatment. So I would rather focus on things that are safe. And I think people are playing with other women's lives by saying, you know, it's okay to have a hormonal therapy when you have had a hormone-dependent cancer.
Well, just because you've briefly touched on that there, what is a hormone-positive breast cancer and hormone-negative breast cancer, just for people? Because I feel like if someone's had a breast cancer, they would know, but other people might not.
So there are different types of receptor status. Women can sometimes have estrogen receptor and progesterone receptor positive breast cancers, and HER2 receptor positive. So we would try to find out what kind of receptor status the cancer had before making any decision. And lots of women are now picked up on screening, or they might have DCIS, which is ductal cancer. That's been totally cured by, say, surgery, no other treatment required. And those are the ones where I think we can probably be a bit more flexible. Or, say, younger women who've had triple negative, so no hormone receptor positivity within the cancer. But I still think it's important to liaise with their team, their breast team.
And the thinking behind that is, so if someone's had a hormone receptor positive breast cancer, if you then give them hormones, you might
feed
up the
trigger it
promote
again.
recurrence. Whereas if you're hormone receptor negative, in theory, that's less likely to happen, but still, as Paula
they
says,
do have a slightly increased risk of a further cancer, which would be estrogen receptor positive. So we've massively reduced our waiting list, but this is just an example of something that happened to me. At one point, our waiting list was 52 weeks, and I think it's now down to 26 weeks from 60. So it's gradually coming down as a result of the collaboration with GPs. But I had you read the letter before you have the conversation with the patient, and this was a patient with a history of breast cancer looking for HRT. But by the time I rang that woman, she already had stage 4 breast cancer, so it spread. Wow. And, you know, I thought to myself, gosh, if I'd given her HRT, I would have felt very responsible for what happened, and it was going to happen anyway. But yeah, it's just an example of, you know, that risk is always there, isn't it? Vaginal estrogens, and I think that was one of the questions, are a completely different situation. And the NICE guidance, the current NICE guidance, does reflect that. So most women who've had breast cancer can now have vaginal estrogen. There's a huge study published last year with about 50,000 women, and there was no change in end all-cause mortality if they were provided with vaginal estrogen, but that can make a massive difference to quality of life. You know, pain, vulval discomfort, recurrent urinary tract infections. The one situation where there's still an element of doubt is women taking aromatase inhibitors, because they're basically meant to get rid of estrogen altogether. And it's kind of counterintuitive to then give estrogen. But actually, if you treat those women really early, they don't then get the thinning of the lining of the vagina, and they're much less likely to get any significant absorption.
As in, if you give them vaginal estrogen
early on,
rather
than waiting until it's really severe, better to get in early.
It's difficult though, isn't it? Because you need to then be like, you've been diagnosed with this before, like, you have a problem. Shall we give you something that might prevent the problem, but also make it less likely?
I think we just treat them when they were minimally symptomatic, and that's probably more sensible.
Should we talk about urogenital atrophy? Because we've talked about perimenopausal symptoms, but we've not talked in depth properly about what that is. And we wanted to go on to that a bit later on anyway. So do you want to tell us about genitourinary syndrome of menopause?
So that's the current terminology. There are about 10 different names for the condition, which is confusing. About 80% of women will have symptoms related to low levels of estrogen post-menopause, even women on HRT. So the symptoms are vaginal dryness, itching, burning, pain with sex may become impossible, and recurrent urinary tract infections. Another issue with it is there's no defined way to make the diagnosis, so it depends who you see whether you get the right diagnosis. If you get the right diagnosis, you get the right treatment, which is generally vaginal lubricants, moisturisers, vaginal estrogens, and there's lots of different types. There are pessaries or creams generally, and then there are some newer treatments. Progesterone is DHEA, that's a precursor hormone that gets converted within the cell to just the right amount of estrogen and testosterone with minimal absorption. And ospemifene is a selective estrogen receptor modulator that stimulates the receptors in the vulva, vagina, bladder and urethra, but it doesn't impact on the receptors in the breast and the uterus, the womb.
That is cool. Is that just because it's localised rather than being like systemic?
Yeah, so the localised treatments are better for a localised problem. And ospemifene, which is an oral medication actually, I tend to reserve that for women who find the pessaries really difficult to use, or the creams, and that little tiny, looks like a Canderel sized tablet. But particularly,
it goes up,
particularly older women can find that really quite difficult if they don't have the manual dexterity, or they just, sometimes women just don't want to keep putting something in there if there's a problem there.
Valid.
They prefer to take something orally.
Magic tablet.
Well.
So just say one thing about laser. So NICE has said very clearly laser's not to be used except in a research setting. Lasers are out there. They're like, people have got really sort of divided views. I've had experience of laser therapy for urogenital atrophy for about 6 years, and I think it does work. I don't think women would pay a lot of money. The machines are really expensive, so the treatments are expensive if something didn't work at all. And we have had women who've not been able to have sex, they've not been able to use vaginal estrogens, who've then been able to have sex. So I think it does work, but we do need a really good quality randomised controlled trial.
What does the laser do?
It
is CO2 laser.
I'm just seeing someone being zapped.
It causes microabrasions, and that stimulates fibrocytes, which are dormant cells, to become fibroblasts, active cells, and they make connective tissue. So it really does exactly what vaginal estrogen does, and it improves the blood supply, the nerve supply, but it's non-hormonal. So, we've got the neuroendocrine therapies, which are non-hormonal for women who cannot or don't want hormones, and it's useful to think, or it's good to think, we may have a non-hormonal treatment for GSM, but we do need that really good quality.
So currently that's only available in a research setting or privately?
Yeah, so the Liverpool Women's have now got a self-funding stream, and I think if you're going to have laser therapy, it's really important you have it with somebody who really knows about the condition primarily.
You're not getting shooting like
I was like, did you shine it
know what they're doing down there?
So everyone's been trained, and we've got a new machine, and we've started a self-funding stream.
Does it hurt? Does it like burn?
No, it does burn because you can smell the burning. The vaginal treatment doesn't hurt, but the vulval treatment is a sort of dot technology. So what it does is it burns and it ablates, but it only does that to a tiny bit of tissue.
So you would feel it.
You feel that, but it's not horrendous, but we generally offer a numbing cream beforehand.
I'm thinking like laser hair removal.
I'm thinking laser tattoo removal.
They're different lasers, but
yeah.
Different lasers for different things. I'm only really mentioning that because I think people are going to all kinds of places to get that type of treatment, and it's good to come to an official place. But I also think it's good to know that there are different treatment options, because people get really upset by GSM. They feel like it's ended their sex life, and that's a really important part of your relationship. So just to know that hopefully at some point that might become available on the NHS, I think is good.
And how do you approach menopause care for people who haven't got their ovaries if they'd had them removed?
Yeah, so a surgical menopause, when you've had ovaries removed, is a much more extreme, much more difficult menopause to manage. I think we need to work on making sure that women are counselled properly. So before they have a hysterectomy, a lot of women, I think, have that conversation, and there's not a lot of focus on it's going to be a much more difficult menopause to manage. So like the women with the premenstrual dysphoric disorder, absolutely end of the line treatment is to remove the ovaries and the uterus. But that has to be balanced against how we're going to manage that surgical menopause. So I mentioned at the beginning about in my week, we do an implant clinic on a Thursday afternoon. Implants have been problematic. They're not licensed, and they're not regulated in the same way as other medication, but they're an absolute last resort for women who don't respond to other.
Is that like the arm?
No.
That's what I was
So the
thinking,
arm is like a matchstick, whereas these are tiny little pellets that go into the skin on the belly generally.
Okay.
Yeah,
I don't think I've heard of this before.
No, so at the moment the testosterone implants, the company that make them have found some contaminants, so all of that batch has been withdrawn, and we had a previous problem. So what we really need is a licensed product, because it's a really, really valuable resource for women who don't respond. So like we were talking about, you might have somebody on 4 pumps of estradiol who's just got like less than 100 picomoles of estradiol. You put an implant in and their level will go to 600, and they feel like completely amazing when you do that. So I think they're a really important resource, but they're just fraught with various difficulties at the moment.
You know how we're saying there that like some people just try and increase the pumps. Do you get any kind of like resistance?
Yeah, you absolutely do. So if you keep increasing, so I've seen somebody who was on 100 microgram patch, which is the top dose, and she had 9 of them on her body.
9.
And she didn't even probably need 100, and I don't know why that happened, but I think it's just there's some stuff out there that's going really off. Or we've got people who are using 10 pumps of estrogen when the upper limit is 4, and you flood your estrogen receptors. You get something called tachyphylaxis, where you start becoming symptomatic again. And then, if you're the patient and you think, well, I'm now using 8 and I'm sweating, I must need more and more and more.
So it's like
that's why I think we just need to take a step back, and nothing wrong. There's absolutely nothing wrong with HRT, but there's nothing wrong with standard doses, and it's not a cure-all.
I think the chat with people who it's very difficult. So when people are coming in for a surgery and they would like if they're having a hysterectomy, so their womb removed, but they're kind of less than 45 years old, this chat about ovaries, should we remove them, shouldn't we, is a difficult one, because they're like, but I don't need them anymore, and you're like, but you do need them.
Yeah, so they continue to produce estrogen a little bit and testosterone.
You need them for all of the things. But having that thing, but then they'll be like, but I know somebody who knew somebody that had ovarian cancer, and obviously if I don't have my ovaries, then I can't have ovarian cancer. And it's a really difficult conversation, and it's all right you saying, but you're going to have a surgical menopause. So today you are not menopausal. Tomorrow you will be menopausal. There isn't this like bit of like
ease into
up down. It will just be like a
literally
overnight thing. But people, unless you've gone through it,
the number of women in our clinics who are saying, I would never have done this had I known. So that some of that sort of peer support I think is really important. I didn't mention we'd also trialled doing group consultations. The women loved it, but so we do group education, and we're going to carry on doing group education, that's a really positive thing. But at the start of the group consultation, we did an education session which they all loved, but then they all wanted an individual because they'd all waited a long time. So I think it probably works really well in primary care, where it's your patient and you don't have to use our computer system and dictate a letter and all the rest of it. But it's not great, I don't think, for secondary care. But it was very interesting how much the women liked being together and sort of sharing the burden of their symptoms.
I know, we spoke about this before. People do like to speak about their experiences.
Yeah,
I think it's good and bad, isn't it? Because you have the people that would want to speak about theirs, and that would make you think, oh, I've had that, or I did. But then you'll have some people that just won't say anything, and they'll come and actually will have been just no benefit for them whatsoever. I suppose.
I felt worse afterwards.
What we found was the women who were in the group who had surgical menopause were like, this isn't really relevant to me. I'm not in the right group. So I think if we did carry on, we would just have all surgical menopause, all women wanting testosterone. That would be a good way of managing that.
Yeah, that's a good idea.
What about endometrial cancer in HRT?
Yeah, so for most endometrial cancers, we can give HRT, but like I said, we tend to make sure that the gynae-oncologist knows what we're planning on doing. It depends on the type of cancer, of womb cancer. There are some types that we wouldn't give HRT. There's actually now a really good guideline which was jointly developed by the British Society of Gynecological Cancer and the British Menopause Society, and you can just put the type of cancer in and see whether it's controversial or it's okay or it's contraindicated, and I just use that all the time.
I like that. And of the people that you think they would benefit from HRT, and I know we've talked a lot about people wanting HRT in situations that might not be correct or might not be beneficial. What about for the people that you think it's beneficial but they're actually just really worried? How do you kind of counsel those people?
Yeah, so I mean, I think we can talk about using things which we think are associated with least risk, so maybe using a small sachet of gel with micronized progesterone, or dihydrogesterone is probably the next safest progestogen, and that's just become available again. It was available years ago. But some women, it doesn't matter what you say, they'll listen to that, and you might prescribe it or ask the GP to prescribe it, but they'll still not use it. So you can only provide the right information, and at the end of the day, if it's going to be more stressful taking HRT than not, then it depends on what their symptoms are, I suppose, as well.
It's their choice.
And then, the other question out there is, should people be staying on it forever? And I used to honestly think I would stay on it forever, but I think I feel like so overwhelmed by the current situation, as I think I would definitely stay on it while I was working, and then gradually reduce the dose and stop and see how it was. I mean, if you're asymptomatic, then you don't have to take HRT forever. I mean, I think one of the myths out there is that if you have HRT, you're not going to get that sort of deposition of fat around the middle. But I think that's partly ageing, and I think it's also linked to lifestyle. I've got it.
As you get older, just treat yourselves, it'll be fine.
Do you see people who have stayed on HRT till they're like 80s, 90s?
Yeah. You do, and you see some amazing women. I had a patient, and she was in her late 70s. She was actually on ethinyl estradiol orally, and I was like, oh my God. And she was really smart, because she said, well, listen, if I was going to have a problem, I'd have had it by now, but I couldn't bring myself to prescribe ethinyl estradiol to somebody who was nearly 80, but she was right.
Yeah.
But it's just a tricky situation. So basically, as women get older, like over 60, if they were on oral estrogen, you would want to transfer them to something through the skin. But at the same time, if you transfer them and they hate it and it doesn't do anything for them and they were fine, is it okay to
and
go
if
back?
they have a low risk of cardiovascular problems and blood clots, I suppose you can, if they're aware of the risks and they'd find benefit from it.
I think there has to be flexibility. And I think the problem with guidelines and recommendations for other clinicians is people seem to want absolute, what do I do in this situation, in this situation, this, and you can't provide that. So we need to be a little bit flexible as clinicians. And I think as long as we say to patients, I don't actually know exactly what your risk, because we don't know what the risk is. We pick up loads of women with high blood pressure. And I think people forget that the risk of getting high blood pressure goes up as they get older. The risk of becoming diabetic also goes up. So we do kind of pick up lots of comorbidities, and I think that should be done in primary care.
On the note of other comorbidities, we've touched on like cancers, but if somebody has, a risk of blood clots or like liver disease, is there other considerations you have to take if they're maybe going to start HRT?
So a lot of our referrals are for women who've had a blood clot, either in the leg or the lung. And actually that population mostly can have estrogen through the skin.
Okay.
The haematologists in Liverpool are very knowledgeable about HRT, and sometimes if it's women who've had recurrent blood clots, I might be a bit anxious, but generally speaking they're really supportive. And the other group in Liverpool is that are really, really on board with menopause is Liverpool Heart and Chest. So they get a lot of women who present with palpitations and who are actually perimenopausal, and they won a poster prize at the British Menopause Society for the work that they've done.
I love that.
And we're just publishing a Tales from the Clinic with them, and it's a tale. This is a useful tale to know about of a woman who had an injection to induce a chemical menopause and had a cardiac arrest.
Oh God!
And it is on the leaflet, but it doesn't happen very often. So women who've had any sort of arrhythmia, we need to be really careful with those women. And we wrote that case up just because it's like, oh my goodness, she's okay, the woman. But
Good,
yeah.
glad to hear it.
We were like, do we ask?
I know, I'm like, is that trauma?
very, very traumatic for her.
Oh, I'm sure.
And what do you do about women who might start HRT but have some bad side effects or not? It's not working for them.
So women should have a 3-month review and then an annual review. So as a sort of secondary care specialty, we can do the 3-month review, not always at 3 months, but we do a review and then hopefully discharge the GP, and the ongoing annual review should be with the GP. The problem is finding the right thing. So if they're not right at 3 months and we have to try something else, they remain within our system for a lot longer.
Almost like trial and error.
Yeah, and it is difficult with some women. What I do, if women say, I've still got this and this and this, I would do an estradiol level, and I think we do far too many, but it's quite useful to know, are they actually getting any benefit? Is the level therapeutic? And if it's not, then that's why they feel awful. And if it is therapeutic, then we look at another reason for why they don't feel so good.
Mm-hmm. We've talked about neuroendocrine drugs and laser, so sort of non-hormonal treatments for menopausal symptoms. Is there anything else that you regularly use or think is beneficial for people?
We've been using antidepressants for the beneficial effect on hot flushes and night sweats and mood-related symptoms for a long time, outside of licence to manage hot flushes and night sweats. So we specifically use mirtazapine, which is really good for sleep, but it can cause weight gain, so that's a limiting factor, or venlafaxine in a slow release preparation in a very low dose. Both drugs we use in a low dose, and we also use oxybutynin, which is a drug licensed for overactive bladder, but it's not a very nice drug. It causes terrible side effects, dry mouth, but we use it in a very low dose.
Okay.
But the results actually with oxybutynin, I think, are not dissimilar to what you get with neuroendocrine therapies, but it's nice, I think, to have a drug licensed for the reason that you're using it, and I think they will make a big difference, because trying to get women to use antidepressants, even if you say, I know you're not depressed, that's not why I'm giving you this,
it's hard.
they don't want to be labelled as having depression.
And do you know of any like herbal remedies?
Herbal remedies, it's quite difficult as a clinician to recommend herbal remedies, but things like red clover, which is a phytoestrogen, do work. And when you're thinking about coming off HRT, using red clover, I think, is a really good way to transition from HRT to not. You don't need a progestogen, and generally speaking, progestogens are the more problematic hormone. Another really odd thing that's happening at the moment is people are being told that they need progesterone for all kinds of other reasons, for sleep, for various other symptoms, and we use progestogen to protect the lining of the womb, and progestogens and naturally occurring progesterone are probably the trigger for breast cancer. Once you've got breast cancer, then it depends on the receptor status, but I wouldn't recommend women using a progestogen if they didn't need it, because these various symptoms that are in the public domain are not an indication.
By a progestogen, do you mean like progesterone?
Yeah, so progesterone is the naturally occurring hormone, and you can make progesterone, but it's not orally active, which is why we now have something called micronized progesterone. That's to make it orally active, and progestogens are
They sound too similar.
They're the synthetic hormones. And I think
the same thing.
patients talk about progesterone as an all-encompassing term. Basically.
And when you're talking about using a progesterone to protect the line of your womb, I think that's what people understand a bit better.
Yeah.
That was one of the things that came out of the NICE guidelines as well, that they didn't talk about. Everybody thought that maybe they would talk about the Mirena or a progesterone releasing coil, that this would be a lower risk. But
it's not. I don't think
there wasn't anything that came out with regards to that, and I think everybody was like, but we thought that this was a good idea.
I think the main thing with Mirena is it's fit and forget, bleeding. Isn't it? And the bleeding is not an issue.
Much better from that side, I think. Yes. So many women are caught kind of between like vague reassurance. How can we? It's really difficult, I think, with this risk-free benefits situation, and I think expectation setting also comes into it. And when we've discussed kind of briefly about NICE guidance and what we think that HRT can help with, how do you discuss risk benefit with that? What's your hard line? Like if you were saying somebody wants to go on HRT, you need to know that you have, what risks do you tell people?
Yeah, so you want to make sure that you've talked about family history of things like breast cancer, that you've made sure that they've got no significant unmanaged comorbidities. And then I think you have to give them what we understand now as factual based on, various different research studies. The SWAN study, which was done in the States, has highlighted the fact that continuing with 2-hormone HRT over the age of 65, or starting it, I think it is actually over the age of 65, increases the risk of dementia. And the word out there on the street is that HRT will protect against dementia, but dementia is multifactorial as well. So I think all we can do is go through various different things that happen to women and give women the benefit of research, factual evidence, but as an individual, you don't know what's going to happen to anybody, do you? And I think, what I would like to get back to is that women didn't have difficulty accessing menopause management, but they had treatment options available. It doesn't have to just be HRT. It might be neuroendocrine therapy. It might just be vaginal estrogen. It might be mirtazapine because they can't sleep and that's their most significant problem. But there's no blanket because everyone's so different as an individual.
So we're going to move on to some quick fire questions and myths. So number 1, how long can I take HRT for?
So that depends. It depends on how bad your symptoms are, what you as an individual want to do. Nobody has to come off HRT at a specific time. And equally, nobody has to continue with HRT forever. So it's based on an individualised ongoing risk assessment.
So sort of on a similar vein, how long of taking HRT before I can expect to feel the benefits and symptoms relieved? And
so I think generally within a week or so you would know whether it was going to be right. But we review women at 12 weeks to give them
a chance to
12
really
weeks really to see whether they're responding.
So how do I stop HRT? Do I stop suddenly or do I reduce it gradually?
Yeah, I mean, again, that depends on circumstances. So you might have a diagnosis of breast cancer, say, and the surgeon says stop your HRT immediately. But in general, if it's just that you've decided to stop HRT, I think women are better to gradually reduce the dose and then stop it. They're much less likely to get rebound symptoms if they do that. And I would also say to women, if you drop the dose, you might become symptomatic again, but give it a bit of time because chances are that the symptoms will settle down again.
Yeah. How would they do it gradually if they had like a Mirena?
So the Mirena stays. It's the estrogen that you reduce gradually. So, for example, you might have somebody on 2 pumps of estradiol that reduces to 1 pump and then half a pump daily.
We've had a question that someone thought HRT always contained testosterone and this causes mood changes, and I think we hear a lot that it causes aggression. Is there any truth in that?
I suppose it can do, but Yeah, and again, it goes back to how much testosterone are people using. We see some really shocking levels. I didn't really talk about that, and we think they're contaminated samples, but it always worries me that they might not be. So if that happens and we have a really high level, like the upper limit in our lab's 1.9 nanomoles per litre, so we might see a level of, 15, which is horrific. Wow. We tell them to stop, and then we carefully restart.
So is that you're thinking like the medication's contaminated?
No, so where they get a blood sample from. And it's hard when you think about
through testosterone.
If you think they're putting it on their lower abdomen, you're taking the blood sample from their arm, but it does seem to be an issue. There is one type of HRT which is taken orally called tibolone, which is different. It stimulates receptors, estrogen, progesterone and testosterone receptors, and actually I think it has a real place, tibolone, for women who are sensitive to progesterone. So we use it for the women with PMDD. It's quite low dose and they may remain symptomatic from a menopause point of view, but it's at least something they can tolerate, and it doesn't increase the risk of blood clots, although it's taken orally.
You know, the testosterone, you know when people have like vitamin injections and they feel like better, and then what happens is they need it like closer and closer together to get this thrill of like feeling better. Do you find that with testosterone?
So I think there's a massive placebo effect with testosterone, which is where I thought you were going with the vitamin injection. I think with the implants we definitely get that, and that's part of the counselling. We say you're going to feel fantastic usually for the first 4 months, and then you're going to feel like you need another one, but if we do your bloods will be fine. So we're kind of not going to do your implants too soon, because with implants you build up on a level, and
so then you get the resistance.
Sooner. Placebo effect is definitely a thing. If I ever have a headache and take a paracetamol, I'm convinced with the minute after I'm like, oh, I'm better. Another question, is vaginal estrogen ever safe after cancer, even if systemic HRT is not?
Yeah, so that's something that definitely has changed, the fact that we can give most women who've had cancer vaginal estrogen, and I think people have really underestimated the impact that severe urogenital atrophy can have on well-being. It's almost like women will accept those symptoms as a natural part of ageing, rather than thinking that they might be able to be treated with a hormone and be completely asymptomatic. They soldier on for a long time. And access to vaginal estrogen, you can buy it over the counter now, so that's good.
Can you?
Two different types of vaginal estrogen. So that's good, and but women shouldn't have to pay. And actually, we now got certificates for HRT that mean that women can have a year's supply for about £20, which is really good.
That's great. So our next question is, what are your thoughts on creatine and its benefits as a supplement? And this is sort of either alternatively or with HRT, because the person who's asked the question says that they've found really huge benefits with cognitive performance, and they would like to see this recommended more widely by GPs.
So I mean, look, I don't recommend any supplements at all apart from vitamin D and calcium. We are, as a nation, vitamin D deficient, and actually we had a really interesting talk from Alex Komninos, who's an endocrinologist at Imperial, about lack of calcium. And somebody was saying to me, well, you can use a calcium calculator, and I was like, I don't need to. I virtually have no calcium in my diet, so it's really like, I know I should take a calcium supplement. Creatine, I think, is one of these things that's being a bit hyped at the moment. That's my personal opinion, and it probably goes in one end and out the other, and I don't think it has any part to play in menopause management. So I wouldn't like to think that we put more pressure on GPs. I mean, the testosterone thing is killing GPs as well. So yeah, I think if people want to buy supplements, that's their decision. If you have a really healthy diet, you should get most of what you need in that diet.
But is it one where, like, if it works for you,
if it works for them,
you feel great, you keep doing it.
Yeah, and it's not costing anybody else, then no problem.
Also, clearly, I'm thinking, why has Paula got no calcium in her diet?
I know, I'm like, where's the cheese? Where's the milk?
I do eat cheese. I do eat cheese and a tiny bit of milk and eggs, I suppose. Hardly anything.
Yeah, eat more cheese. Life would be better if everyone
when we
had
had our dentist guest on, cheese is a very good snack because it's not sugar. So if you want a little snack, just go and get yourself a little block of cheese.
Neutralises
So this is two that have said more cheese.
Yeah,
more cheese. More cheese.
We are.
Do you think we could manage the menopause with cheese?
Probably.
Maybe we should get sponsorship from like Cathedral City.
Baby Bell. Any Baby Bells?
Anyway, back to the questions.
How important is muscle growth or maintenance of staying fit and healthy through perimenopause and menopause?
It's really important. And, you know, like all women have to do is walk for about 20 minutes, 5 days a week. That's not that difficult to fit in. And some weight-bearing exercise, and you get loads of yoga and Pilates online. Dancing, we should all be doing more dancing.
I'm happy for dancing. Yeah. Love a dance.
I've got a terrible, back to my diet, West of Scotland diet, really bad diet.
Do you counteract that with the dancing?
Yeah, I'm contracting my West of Scotland diet with dancing. I love sausages. I mean, it's really I'm trying
battered or not battered?
Deep fat fried,
deep fat fried sausages.
You do get them from the chippy at home.
Yeah, I don't
Deep fat fried, you get that in the chippies everywhere.
Yeah.
Well,
Not the most.
I would definitely say
Not special. The next question is, do you think the myths are starting to be expelled around the safety concerns of HRT?
Yes, but there are new myths replacing the old myths, unfortunately. And so, you know, it is unfortunate, I think, that we've made a lot of progress with the old myths, but the new stuff, I think, is overtaken what was there already. And we do, like, you know, I've been criticised for saying things have moved too quickly, but they have moved too quickly because you cannot provide education and support for GPs overnight, and that's where we need to focus, I think, educational support, really.
Yeah, it's also hard because anyone can put information out there. So, and anyone could start a myth.
So I would say,
I was going to say, that's why I started stirring. So I was like, we would never.
If it wasn't for the fact that people might want to access this podcast via social media, I'd say stop all social media.
And if you had one piece of advice for women at the start of their peri journey, what would it be?
To sort out bleeding, which is probably, well, it is the commonest symptom of perimenopause, to think really carefully about, do I want to make my quality of life better by something like Mirena, which can reduce bleeding, improve haemoglobin, iron stores, and much less likely to get depression if you have all of those things. So get the right information and do something really positive for yourself.
Yeah, it's difficult. I just feel like it's difficult promoting.
It's not for everyone, is it? But, you know, I'd say, and it sounds like cat food advert, but 9 out of 10 women would benefit.
9 out of 10 cats.
Paula has looked into her cats and 9 out of 10 of them.
No. The problem, I think, comes from when people come with their preconceived idea about how bad the Mirena or whichever device is, and then you try and break that down with actually how it could benefit you. You're kind of already fighting a losing battle. Which is tough, and that's all social media myths, I think.
But also the reverse of coming thinking it's going to solve all of your problems ever.
And obviously some women can't have it for anatomical reasons, so it's not there for everyone.
Some of the combined pill options that you've said before would be really good options, because as we've said, if you don't want to be pregnant, whether you're 30 or 35 or 40, like, you need to be on contraception, so these would like be.
And the number of conceptions in women over 35 in the UK is rising, and that's not because they want children necessarily, so some of that's unplanned pregnancy.
This leads so nicely into our first myth.
Yay.
You have to stop taking contraception as soon as menopause begins.
No.
We want to surf that transition with contraception.
I like that. Surf the transition.
What do you, let's say this properly. So what age do you tell people they need to be on contraceptive
so, like,
for?
the now College of Sexual and Reproductive Health says 55. We had a case yesterday on the GP Teams meeting of a woman who didn't stop her periods till she was 61.
Wow.
So I think people are probably as a nation healthier because you know, we get a better diet in many ways, but people are menstruating for longer.
So definitely keep going with that contraception unless you want a little one. Okay.
Testosterone replaces the need for estrogen, so trans men can't have menopausal symptoms.
So trans men using testosterone can have menopausal symptoms, flushes, but obviously for a trans man, using estrogen is not an option, and they can also get quite severe urogenital atrophy, and they might want to use vaginal estrogen but not systemic estrogen.
I think like that one would be something that a person that you would see in secondary care, and you wouldn't expect someone to go ahead and
or in a
manage.
specific trans service.
Okay, and the next one is all women's ovaries stop functioning entirely after menopause, so they no longer produce any hormones.
No, so I mean, no, that's definitely a myth.
Still got them.
Yeah.
They still produce some estrogen and significant amounts of testosterone, and women also get testosterone from their adrenal glands, so there is still hormonal production post-menopause.
Another, menopause makes women irrational.
Lots of things make lots of people, men and women, irrational.
Very inclusive.
Back to the issues that we said previously. It's not just your
can't
hormones
just blame
that
the
can
menopause,
make you
yeah.
irrational.
Yeah. HRT changes your personality entirely.
It absolutely doesn't. So you know, your personality will remain the same. What we aspire to do is to replace the hormone levels so that they're more similar to what they were pre-menopausally. And in sort of reproductive life, you've got cycling hormones, changing hormone levels, which can be quite difficult to deal with. So ideally, post-menopause, it would be a low but sustained level of estrogen.
More stable.
Yeah.
If you take HRT, you'll get your period back.
So you don't get your period back. You might have a withdrawal bleed, or you might have irregular bleeding, which can be quite annoying. But if you've been a full 12 months since a last normal menstrual period and you have 2 hormones, what we're aiming to achieve is that women are bleed-free.
Fab. And then finally, menopause symptoms run in the family. So your mum and your gran are a good person to look to as an indicator of what your menopause will be like.
Yeah, we've kind of always said that, but I suspect that might be a myth, and lots of women don't know what their family history was, or they may have had, you know, the mum might have had a hysterectomy or something, so it can be quite difficult to say that for sure.
Well, thank you so
Thank
much.
you so much.
We've definitely done a whirlwind tour of all things menopause, the
Yeah.
good, the bad, and the ugly.
The flushes.
And the flushes.
Lovely.
Thank you.
Well, it's been great to have you on, Paul.
Yeah, it's been very jolly.
So just a little disclaimer, everything that we've discussed are our own personal opinions, are not affiliated with where we work, and should not be taken as personalised medical advice.
Yep. And if you've enjoyed this episode, if you've learnt something new, please make sure you leave us a review wherever you get your podcasts.
It may seem a small thing, but if you give us a 5-star review, it pushes the podcast out to as many people as possible so that we can go on breaking down barriers, busting myths, and giving out really good quality information.
Yeah, and we really want this episode and the whole podcast to reach as many people as possible. So if you want to be part of that ripple effect, then please hit the like button.
And make sure you're following us at Between Two Ovaries on all of our platforms and engaging with our content.
Thank you.